speaker is Dr. Hernandez-Montfort. He's going to talk about, have a case presentation with valvular shock hemodynamics.
Thank you. It's an honor to be here. Thanks, Marwan. Thanks to everyone in Houston Shock. It's always an honor. These are my disclosures. So what I thought for today was maybe invite you guys to selection committee. And these are the cases that come through us every Tuesday morning. And as data is being presented, we're starting to try to define or redefine a common hemodynamic language. And as we try to endorse early invasive hemodynamic monitoring, the reality is that these patients will come in with recurrent acute decompensative heart failure, with known heart failure with reduced ejection fraction, with bilateral signs of congestion, perhaps originally thought that they have a stroke because they were obtunded. Once we started looking closely, an elevated lactate, worsened renal function with low urine output, and you get the call around 1 a.m., what to do next, activating the cath lab at that point, when you have a 69-year-old gentleman with a known history of ischemic heart disease, mitral regurgitation in the severe range, arrhythmias, and a prolonged history of interventions, including CABG, PCI that require percutaneous transvalvular pump and ablations. I think we decided to empirically treat with an inodilator and decongest with furosemide infusion. So after that, the next day, these patients will usually be scheduled for an invasive hemodynamic profiling. We have talked about this at length. There's major value of complete and quality invasive hemodynamics, as shown by Rashad and the team from the Shock Working Group. These hemodynamics are being presented on our meetings, and it's important to put these single snapshots into context. This is 48 hours after initial admission on milrinone at low dose and decongestion ongoing that normalize the lactate and improve the renal function. But as you can see, there's still signs of bilateral elevated loading conditions with preserved myocardial performance. And when we look closely at the echocardiogram, the ejection fraction is reported at 35%, the dimensions 5.8. It's noted to have a previous mitral clip and severe residual functional mitral regurgitation is noted. We looked at that's 9/28/21 left heart cath, and his grafts were overall patent in terms of the lima to the LAD. There was occlusion of the SVG2OM, SVG2PDA, and essentially at that time as well elevated filling pressures, but really nothing to consider for revascularization at that time. When we look closer to the valve, as hemodynamics were suggestive of a concern for out of proportion or disproportionate mitral regurgitation, the echocardiogram confirms that. When we look closely and trying to endorse bringing the tracings to the selection committees, we see, as you can see in that post-PVCV, that the V-wave of the wedge pressure on milrinone is almost 70, 68. So again, we look at the labs. Creatinine is normal, so end organ function, renal and hepatic function has normalized. There's some signs of anemia, perhaps suggestive of chronicity of disease, and perhaps as well that related to the abnormal TSH. But overall, the patient has, we'll say, effectively decongested after a few days of inotropic support and PA catheter-guided therapy. So 2 weeks in, or 10 days in, we repeat invasive hemodynamics. We see that right and left heart loading conditions have improved. Still, we continue to see V waves, but at a much lower range and preserve myocardial performance. And at that time, we repeat our imaging to look at the area of concern that at that time was mitral regurgitation. Still see it. And when we look closer through TEE, there's really not a problem with the prior mitral clip, but there's still MR. So in this context, in this world of the different subspecialties and heterogeneous talent, we try to get the talent connected towards interdisciplinary systems of care-driven decision-making, and really trying to transmit the real-world data that we have in this context of shock that is limited to several retrospective data into trying to define what is best for that particular patient. And in this context, it's important to understand that when somebody is presented to selection committee, that doesn't mean that they need to have a replacement therapy, and trying to understand if there's an opportunity to, of course, preserve native heart survival, and it's okay to have heart replacement therapies and, of course, palliation as backup. The important thing about these cases is that the transitions are very important to, in the sense of execution, and trying to avoid this stage D and E, particularly in heart failure, as I think back and reflect on this case, is really important in the sense that we can perhaps anticipate these patients when they're referred early to us. So our case, in terms of decision making, we invite the structural team, the cardiac surgery team, to our selection committee. Their perception was that native heart survival strategy was perhaps the next step. We opted for preoperatively Impella 5.5 within 24 hours, mitral valve repair open, and replacement therapies as backup. So just some still frames of the mitral clip. I don't know if this is going to show. Initially, the valve was considered to be replaced, but they were able to repair it. And this is the final sort of sign of it. This was pretty much this week. I think it was Wednesday when he got the operation. This is last night. As you can see, at least from the surrogates of myocardial performance, patient is starting to wind down on the performance level of Impella 5.5. And again, we have all these adaptive protocols to try to wean and recover these patients after high-risk surgery on transvalvular pumps. What I was thinking is that these type of cases really need to be studied much more than just the V wave, and I think we have talked about this at length. I think Dr. Burkhoff has really translated the basic science towards clinical applications, and as Dr. Brenner and his team of PV loop enthusiasts continue to pave the way, I think we will be able to predict success of our selection between native heart survival and replacement therapies. One more minute. It's just want to thank the team that has adopted me in Central Texas and Greater Austin to lead the way in advanced heart disease. And again, thank you for having me.
There must have been a fair amount of discussion about taking this patient to the OR.
Yes.
I would have liked to have been there for that.
Yes, it's so that's the thing. Sometimes we feel the urge of making a decision in that 10-minute, 15-minute presentation. In this case, we were able to present the regional snapshot of hemodynamics, treat, reeval, and the patient was brought to discussion 2 or 3 weeks in a row. There was a fair amount of discussion, for sure.
Are you using Impella in similar cases with reduced ejection fraction? Is that your concept, or only that's a special case? Or
well, we thought here that we were not sure if after mitral valve surgery, the patient will require then replacement therapy. So we wanted to upfront, have the possibility to support the patient afterwards and define if truly this was a predominant valvular problem with a preserved lima and ejection fraction was 30 to 40% after the valve, he should really do okay to the point that he can keep his heart. It's not, yes, we can do that. We can do transplant at age 69, but that's why the expectation conversation is so important. This patient really wanted to keep his own heart after presenting all the options and wanted to give it a try. And it's all about that trust relationship. I think the future is to have longitudinal invasive hemodynamic assessments that can help you predict better what's going to happen to the right heart, what's going to happen to the RV-LV coupling after you do these interventions.
I think his ejection fraction improved after you optimized him. If you
It
look
did.
to the echo just before surgery, his ejection fraction was,
It was, yes, it was quoted
Yeah.
35 to 40%.
yeah,
So
go to
yes, you're
40%.
correct.
That's why I'm saying
That
use-
that reassured,
I don't
yes.
understand why they didn't do it.
I have a comment and a question. First of all, I want to applaud you for, I think, what is the way we need to be using the Impella 5.5 in the future. And this is something that we do a lot in Atlanta, is these patients who are decompensated, we put an Impella 5.5 in ahead of time, we optimize them, and then we have it on the back end to be able to do these high-risk cardiac surgery procedures. And it's super helpful because you avoid the low cardiac output state problems, renal failure, liver failure, being on a bunch of inotropes for a long period of time. And so I think that's great. My question to you, though, is more about the management that happened before he got in your hands. Had this person gotten a mitral valve repair or replacement instead of a MitraClip in 2020, would we even be talking about them today?
Right.
Well, right, how did that decision get made? And we weren't there for that, but
Yeah, why would he got a MitraClip? So these patients, I mean, a patient was being carried a different organization. We were pretty much de novo consulted, and yeah, I think that's a fair question. I just don't have the answer to that. Yeah.
Dr. Edie?
Hey.
Thank you for that really interesting case. It brought, I think, an important point that was just brought up of doing these cases with Impella as a transition. I just want to make the point of what you were talking about when you alluded to the PV loops afterwards, which is, and it already went into the discussion, the ejection fraction cannot be our guide, neither the LV size for doing these cases anymore. And Dr. Carabello's here, who's one of our greatest valvular heart disease physicians that we all alluded to, but it cannot for many reasons. One, we know that, again, there's so much load dependence to EF under conditions that are not even accounted for with the severity of the MR. We just had a case of somebody who had torrential MR on top of severe for chronic cardiomyopathy, who we took to the OR because he ruptured one of his chordae tendineae. And he's doing fine. And he wasn't a candidate for advanced therapies. And I think we may have used the balloon pump just to transition him. Dr. Rajapriyar took care of this patient. So my point is, there's a lot of dogma out there that I think has been, perpetuated with great data in the past. But those scientists, including Dr. Carvalho, did not have Impella, did not have temporary support, did not have teams like we have now. I think the PV loops is an amazing way to potentially look at the reserve of the heart, because that's the issue you really want to know. Is there reserve? If the EF is 10% of the reserve, and the reserve is good, you may get away with it. If the EF is 30% and there's no reserve, you're not going to get away with it. So I think that, for me, is the Achilles heel, and I would love to hear if the PV loops will help. I think they could. I really think they could. It's just a matter of how do you operationalize PV loops on top of what everything else we're doing in the team.
Agree. Thanks, Eddie.
I think
Go ahead.
I was just going to say that I think this issue is coming more to the forefront with tricuspid regurgitation treatment, where the ability to predict who's going to do well and who's going to do poorly afterwards is getting more complicated, and the right-sided echo assessment is becoming more is not it's not where it's at, and so we've been at Columbia with colleagues working on right-sided PV loops to try to get at this, and actually the group in Leipzig now has really done a lot of work in this on the tricuspid side. Mitral valve, it's a little bit horses out of the barn kind of a situation, but I think there's still hope for the tricuspid side.
shall we go?
Yeah.
Thank you very much.
Thank you.
Thank you.